Thank you. So this is a case that I'm going to present that came to us a couple of years back. It's a 45-year-old woman with a past medical history of a heart transplant in 2000, complicated by rejection and development of allograft vasculopathy in the first 3 years after transplant. She had another episode of rejection in 2005, which was treated. She has a history of hypertension, irritable bowel syndrome, chronic kidney disease stage 3, new onset diabetes, A1C of 7.2%. She was admitted from an outside hospital with acute on chronic heart failure with preserved ejection fraction for reconsideration of heart transplant listing in the setting of high PRAs. The patient was hospitalized with decompensated heart failure in November 2013, December 2014, April 2015, and July 2015. So she was very symptomatic from her restrictive physiology as a result of diffuse allograft vasculopathy. At her most recent hospitalization, she underwent right heart catheterization, coronary angiography, and an endomyocardial biopsy at the outside hospital, with results showing an RA of 17, a PA mean of 23, cardiac index of 2.12. Angiography revealed diffuse transplant coronary vasculopathy. Biopsy was negative for acute cellular rejection with interstitial and perimyocyte staining for C4d. Patient was ultimately listed status 1B at the outside hospital. Inotropes were not started in the setting of severe cardiac allograft vasculopathy and a history of ischemia on prior stress echo. So she was transferred to Cedars-Sinai due to her highly sensitized status for listing at our institution. And this is the single Luminex antigen assay, and you can see that predominantly she has class 2 antibodies at moderate to very high levels. And the main ones are really shown here. We have a cutoff of an MFI of 5,000 for most of our patients as avoids. So you can see that she's got a wide array of DQ antigens, and as a result of that, her calculated PRA is 85%, which essentially means that she has about a 15% chance of having an immunologically compatible donor in the donor pool. So our protocol for patients who are waiting in-house for heart transplantation who are highly sensitized with a PRA greater than 50% is to use a combination of plasmapheresis and the proteasome inhibitor bortezomib. Bortezomib is a drug that's used for treatment of multiple myeloma and causes apoptosis of plasma cells. So our protocol is to do plasma exchange 4 days a week and to give bortezomib on the 2 days per week, and we repeat that for the second week so that the patient gets a total of 8 pheresis sessions and 4 bortezomib doses. We'll then wait for 2 weeks and check a PRA subsequently. If necessary, we will repeat this cycle if the CPRA remains above 50%. And our initial experience with this was published in the JHLT in 2011, and we now have experience with over 30 patients with this protocol showing similar results. Now, why do we use plasma exchange? It's a very effective mechanism for removing antibodies. It removes intravascular IgM much better than IgG. Unfortunately, there's rapid replenishment, which occurs by diffusion from the extravascular space, and therefore you have to give multiple courses to achieve a steady state of IgG levels, as you can see there. I mentioned bortezomib, which is a proteasome inhibitor. Essentially, what happens is that patients who undergo plasmapheresis undergo activation of their plasma cells to produce more immunoglobulins. That increases mRNA production and protein synthesis within the cells. That actually primes these cells for the effect of bortezomib, which essentially inhibits the proteasome inhibitor. The job of the proteasome is really to mop up misfolded proteins within the cells, which if they accumulate, will lead to cell apoptosis. So it's a scavenging molecule that protects the cells under normal circumstances. But by inhibiting it, you end up with accumulation of misfolded antibodies within the cell and induction of apoptosis. So with regards to our patient, the patient received a round of plasmapheresis and bortezomib in September 2015. In November, due to antibody rebound, she received a second round of the same therapy with a reduction of her CPRA to 65%. Unfortunately, the patient hemodynamically declined, requiring initiation and titration of inotropes, and she was therefore upgraded to status 1A. Fortunately, on January 20th, 2016, a donor became available. And this is her flow cross-match that you can see, and these are historical flow cross-matches. The ones at the bottom are from 2015, and as you go up, there is the most recent one. And you can see from September 2015, she had a positive T flow cross-match and a positive B flow cross-match. But following desensitization therapy, her flow cross-matches became negative, and the most recent pre-transplant cross-match on the day of transplant was negative for both B and T flows. For T cells, and this is similar data for the B cells. Although you will notice that the most recent B flow cross-match was positive compared to a negative B cell in prior testing. However, after pronase treating, that became negative due to cross-reactivity. So essentially, this patient ended up having a negative T cell and B cell flow cross-match at the time of transplant. Now, we did observe that we are going across an HLA-DQ2 at a moderate binding range, and also historically, she had an HLA-A2, which we were able to get down with desensitization. So this is important information that we take into transplantation, knowing that there may be a memory response to these two particular antibodies. So here's the DQ2 antibody that you can see following treatment of bortezomib and plasmapheresis, with a significant decline in the DQ2 at the time of transplant, and post-transplant this antibody remains low, and this is a finding that we have noted in patients who've undergone desensitization. And this is that historical DSA to A2, which was successfully treated with desensitization, was very low level at the time of transplant, and actually became negative subsequently without any issues. So her post-transplant course showed asymptomatic AMR on week 1 biopsy. She received prednisone bolus and taper. She did have an episode of Pseudomonas urosepsis, which was successfully treated in February. She developed BK polyoma virus in March 2016. Actually, I forgot to mention, she actually also got a kidney transplant at the same time, but she received IVIG for that. She was switched from mycophenolate to everolimus at 1 year due to her antibody status, and her 1-year coronary angiogram remained normal. The patient went back to her local transplant facility and has been followed there. Her dobutamine stress echo was normal at 2 years, and she had normal graft function as of October of 2018. So here are some of the discussion points. Who should get desensitization? When should it be considered? Which protocol do you use? How effective is desensitization? And what are the downsides to desensitization? And in our experience, the PRA response to plasmapheresis and bortezomib in 25 patients now is that just over half the patients experience a decrease in the class 1 PRA. Just over half the number of patients experience a decrease in their class 2 PRA. The response to class 1 is better than for class 2. Class 2 antibodies are more proteasome resistant. And the percentage of patients with a decrease in their calculated PRA is almost 50%, with an average decrease in of 20%, which means that you've widened the donor pool by a fifth in these patients. So I'm happy to take any questions at this point. Thank you.